So our philosophy on system optimization is developing a structure, the correct structure for the system, the processes within that structure, and using those to drive the outcomes, the Donavedian model, and adjusting the system or process inputs to produce the best possible average response with minimum variability. And taking this into account, we look at the butterfly effect. And so this is what simulation really shows to us. And the butterfly effect is the sensitive dependence on initial conditions where a small change at one place can result in large differences to a later state. So we see that a lot in complex organizations such as healthcare. You make a small change in one part of the process and it has this ripple effect or this butterfly effect down the road. And then when we talk about failure in complex systems, there's really three types of failures in complex systems. The first is a procedural failure, which is just not adhering or executing a defined process. These are what we call special cause variation. We can go back and figure out exactly what happened and fix it. There's engineered failures, which are people, processes, materials. This is what we call common cause variation through our defined processes. And this is where we use a lot of our Lean Six Sigma tools to re-engineer processes. And then we have system failures, which are complex interactions between process and risk factors. They're difficult to understand and pinpoint the cause and effect relationships because of that ripple effect, that butterfly effect. And this is where discrete event simulation really can benefit an organization. So the first project I'd like to show you is an ED flow redesign project. As many of you know, the emergency department is a very complex area, a lot of interacting processes, a lot of different things going on. So to give some background of what we looked at the floor design and throughput for a rapid clinical examination model. This is taking the patients that are less acute, that are less sick, and routing them a different route than the patients that come in that are very sick or that are traumas, those type of things. So we're looking at mostly the large group of patients that are in effect going to go home that day. They come in, they get their treatment or their med refill or whatever it is, and then they're going to go home. And we have 70,000 annual visits in our ED, level 1 trauma center, 500-bed tertiary urban academic medical center, so a very complex environment. We developed the simulation using the floor layout schematic. I like to do that with our simulations because when you take it to the stakeholders, when you take it to the physicians, when you take it to administration, they can look at that and say, this is real. I experience this every day. It's not an abstract concept. We're using the data as it exists in the process to create an actual model of what's happening in that ED. So we wanted to look at our provider resources, how we're developing our whole process, and we used our historic hourly ED arrival rates and service distribution rates for our different patients, and we took a look at the whole flow. So our simulation goals were to determine the most efficient model for routing patients through the system, and then determine the number of provider resources necessary for staffing based upon patient distribution, determine the primary macro factors affecting length of stay for patients. Our length of stay had crept up. This is what we're trying to address. We wanted to identify process constraints and bottlenecks and identify the factors contributing to increased patient wait time and patients leaving without treatment. So I'm going to go to the simulation now. Can everyone see the simulation pulled up?
Yeah, I can see that.
Okay. So here's the basic layout of the ED, of our emergency department. As you can see, we use the schematic to create a basic layout. And the way our process works is the patient arrives. So here's our patient arrivals. And if you click on this, you can see where we've coded the arrivals in the distribution. And if we go into the detail, we look at it by the hour. And so we have patients arriving one every 25 minutes between 5 and 6 a.m. If we go to our busier time of day, we're looking at every 5.31 minutes. So we have different arrival times of when the patient arrives. They go to this, what we call a team leader RN, who essentially does triage on the patient and routes them either over here to this main side or down here to what we call the rapid clinical examination side. And so when we first started this, we said that it takes about 5 minutes with this person, and we route them out. And we were routing, when we first launched our rapid clinical examination list, the physicians developed a red flag list that would say this patient doesn't have any major red flags, they can go through the RCE side, or maybe potentially they have something that would be a red flag that might involve more care, so we're going to send them over to the main side. And when we first launched this, after engineering efforts to put this program together, we found that we're sending about 65% of these patients over to this RCE queue, this less acute side, and 35 to the main queue. And as I'll show you through the simulation, we found out that that's really not a good balance, that probably we needed to revise that a little bit. So we looked at our providers over here in the main queue. I have 5 over here. I have 3 over here in the RCE side. Over up here is the waiting room for the main side. Down here is kind of a waiting area. Now this is more of a virtual. This whole area is the waiting area, but I wanted to separate them. So down here we have a waiting area for the RCE side so that we can look at some of this data. And so here's our treat and release, which is what we're focusing on, those patients that leave that day. And as you can see right now, there's nothing in there. So as I run this, and I'll run it slowly at first so that you can see it, the patients come in, and as you can see, they start flowing through our system. And our providers go to the patient in their room. And you can see through the time of day how they're moving through our system and moving into the rooms. And then you can see them leaving. So here they go. You can see the little graphic. They're on their little crutches as they leave. And the patients that are being admitted to the hospital are going on their beds. So I'll speed this up so that we can just see how this performs through the day. And you'll see when we get to busier parts of the day how this queue is building up here. These are people in the waiting room waiting to get into the ED. Here's people showing up at the door. You can see we've got some bottlenecks in this state. As time goes by, heavy part of the afternoon, 3:30, a lot of people waiting. This process probably isn't optimized, right, where we're headed. So I'll speed it up and I'll finish out the day here. And so let's look at our results. If I look at my waiting room, over here just waiting to get into the exam room, 54 minutes for all, non-zero times 70 minutes. And we found this to be true. People were waiting an hour to get in there and get seen. Not really where we want to be. We want to be around within 30 minutes. If we look at our results, average of 216 minutes through this process. So that's not optimized. That's not where we want to be. We want to be getting down below 150 minutes, ultimately to 120 through what we're doing. So the first thing we started looking at is we said, okay, well, is this red flag mix correct? And so this was a process that we went back and revised, and we were able to fix that so that it's more like a 50-50 mix through some of our Six Sigma efforts and working with our physicians. So we run it again. We can look at our time. It takes down to about 184 minutes, and I'll show you the real-world results of this change as soon as we're done with the simulation here. So then our next move would say, well, maybe we need to reallocate resources. We have people that are a little underutilized over here. So instead of adding resources, perhaps we can reallocate so that we're moving over. So we looked at this fourth lane of physicians in the RCE unit. So we've reduced the number going through, and we've more balanced the provider resources. We run it again. I'm running it pretty much instantly there. And I look at my time again, down to 177 minutes, which is much better. And then let's take a look at what we have here with the waiting room time. And I'll show you the complexity of what the model looks like, the underlying distributions. And so our results here, as you can see, time to get into the exam room has dropped from 70 minutes to 5. And then there's the time waiting for the physician and getting with that physician. This demonstrates the need to have a deep process knowledge when doing this type of work. The simulation Software is very easy to use. You do not have to be a computer programmer to use it, but you do have to have a deep process knowledge so that you can understand all the interactions. So what we're looking at on the main side is we just want to make sure we're not breaking it, essentially. So this is 208 minutes, which is maybe a couple minutes up, but we think we'll get some additional efficiencies from running it. So if we look at 177, then what we can do, our next step is to look at our actual room time. And we know that time with the physician was an exponential distribution of 28 minutes, 28.84 minutes. So by using scribes, we were able to bring that time down. And I'll change these. Take just a minute to do that. Oops. And by reducing that by about 8 minutes, I just go into my properties and I can easily change that for all of them, reduce that by 8, almost 9 minutes. So through some efficiencies through that type of work, then we run it again and we look at our results, 162 minutes. So we brought it down now 50 minutes or so. And so the next step that we're working on through some of our Lean Six Sigma work is then to go in and look at the time spent after the physician sees the patient, which currently about 140-minute average, which we want to get down. We want to get those patients out. So that's the next step to continue moving. But the point is what we can use our simulation for is to make incremental changes and to guide us on what type of improvement projects we want to do. And I'll show you the real-world results and how they match up with what the simulation showed us. So we go back here and we say we determine the appropriate routing model for patients to the main ED in the rapid clinical examination process. We adjusted the provider mix so that we can minimize wait times and patients left without treatment. We know if patients leave without treatment, about 25 to 50% of those patients will return a few days later and they're even sicker, so it's going to increase the cost of their treatment and the complexity of their treatment. And then we saw the number of Lean Six Sigma projects were chartered. So if I go into our actual real-world results, here's a control chart showing our overall length of stay. We wanted to verify that we weren't going to break the main side, which was really all we were watching there as we worked to optimize the rapid side. And you can see from this control chart, it actually improved our overall length of stay on both sides. So if you think about that butterfly effect and optimization of systems, by reallocating the resources properly and by fixing some of the processes, we actually got more optimization on both sides of the process. And so we went from about 248 minutes to 209, as you can see, and this was just by adding the fourth provider. This chart goes back to January 1st. This is where we added the fourth lane. You look at our rapid clinical examination length of stay. So this is from the time the red flag criteria had been amended. So we had gotten down to about 177 minutes at that time. You can see that very much matches the real world of what was happening, and down to 154 minutes, which matches very closely to what our simulation was saying within a confidence interval. And we've continued to optimize this. I can say just the other day, our time was 132 minutes. So that time continues to come down as we optimize, and we use simulation and other tools to improve those processes. Our main side actually dropped quite a bit from 307 to 260. Left without treatment, this goes back to the red flag criteria, but before we implemented this process, we were actually climbing up to almost 4%, which is very high. And from the time the fourth provider went in until really the present time, we're about 1%, a little over. Many days we've had 0 or close to it. And so when we talk about optimizing the system, if we look at the back end, it has made our whole ED more efficient. And so this is a chart showing our admitted patient average length of stay. So this time on the main side, from when we decide the patient's going to be admitted until the time they actually leave the ED. And as you can see, when we added that fourth lane and reallocated our resources, you can see that time just plummeted. When our fiscal year average had been 278. February was 91 minutes. Advisory board 50th percentile is 268 minutes. So for us, that was the second consecutive month below 200 minutes and the first month below 100 minutes for getting those patients out of the ED. And then by reducing that time, here's the control chart showing that a little more clearly. So you can see how that's tightened up and really been reduced, 50% improvement. And then by reducing that wait time from the time they're sitting there until the time they can get into the exam room, the time they see the physician, really has a tremendous impact on patient satisfaction, along with all the other optimizations that we've done as an organization. And as you can see, 98th percentile in February. For our second quarter, which is January, February, and March, for the quarter, 99th percentile in Press Ganey patient satisfaction. So third consecutive month and second consecutive month at 98th percentile or above, which is really an improvement, as we have been kind of down here in this 50 to 60th percentile. By making these changes using simulation to do that, we're up around the 98th, 99th percentile in patient satisfaction. So the key process changes, we implemented this rapid clinical examination model, and then we July 1st implemented 7 days a week from the pilot. We used the simulation and made a red flag criteria change from that in August. In January, added the fourth lane, and then in April, actually took the plunge and remodeled the facilities to support the process flow of the rapid clinical examination model. And the organization was able to get confidence that the model was going to work through the simulation and seeing how it would affect the real world in an offline environment, so that we're not out tampering actually where the patients are, where the work's being done. We can model it, we can gain confidence from it, know we're not going to break it, implement it into the system, and it's a very smooth process. Are there any questions on that?
Todd, I think it's Claire here. I'm from Simulate. I lead on healthcare. Sorry I couldn't speak earlier. I was struggling to get in. I just thought that was an amazing project, fantastic results. What I'm really interested in is how you combine Lean and Six Sigma with simulation, and how you start with the simulation and then go on to the Lean Six Sigma in order to engage your staff and the organisation. I wonder if you could say a bit more about that.
Sure. When we started using simulation in this organization, we had built our Lean Six Sigma program about 3 years ago, so we're really ramping up. We know that it takes a number of years to get a full implementation of Lean Six Sigma, and as we've been ramping this up, we said, well, we need more tools. We're using the tools, but we need more diagnostic tools to understand what we even need to go after from a flow standpoint. And so we took a look at this, and I had used simulation and some engineering work I had done in the past, and I said, let's integrate this into our Lean Six Sigma work. And so we said, if we build the model, the flow model in Simulate, and we can simulate the model, that's going to guide us in what direction our resources would best be spent doing Lean Six Sigma projects. And so by analyzing the data and getting a deep process knowledge of the flow of the whole organization and of a big complex unit like the ED, it's really guided us in knowing which projects then to launch. So as I mentioned, the red flag criteria, we went in and simulated that as part of it, and I said, well, we took a look and said, what if we more balance this out? Are we sure this red flag criteria, which was a first pass, the physicians had created it, so it wasn't a bunch of engineers, it was the physicians creating it along with us. we wanted to streamline that, so we did some lean on that, and we figured out the best way to get the proper care to patients and to make sure we're not overutilizing or underutilizing our resources, and that we're using things appropriately. And so that launched that project. Then, of course, some of the other flow projects, when we're looking at this back end of 140 minutes after they've seen the physician or after they've gotten their test back, that allows us to go use some of our Lean Six Sigma tools to further drill into that using linear regression, those kind of things, and determine that, hey, we really need a project around this to get patients out of the system. We've worked on the front end, now let's get patients out of the system. So it's really allowed us to understand our processes, understand our macro flows, and then drill down and do projects from that.
Yeah, great.
Okay. Todd, I just had a quick question that was more on in the detail of your of the simulation. It was from Ron Dravenstock. I don't know if you're there, Ron. If you can hear that, you can speak. Ron was just asking about. You mentioned 28 minutes from an interaction between the provider and the patient. Just looking for a bit more detail on what was the makeup of that.
Of the interaction.
Yeah, I was thinking it was more on the time scale. Ron was asking whether it was only one interaction between the provider and the patient, or what the setup that you guys have.
Yeah, on that rapid clinical examination side, they'll come in, they'll assess the patient, they'll order the test, those type of things. That's what that initial 20 minutes involves. That back half, that 140, that's where all those activities are taking place, because a lot of them are mid-acuity patients. They're what we call the ESI 3 patients. So they're getting a lot of tests, but they're not going to be admitted. And so that's where most of that work is taking place, where the physician is not present. They've gone on and they're assessing another patient, and they're working on the front end. And so all of that work that takes place after that assessment and after the physician orders the tests, and then honestly coming back and alerting the physician to say, okay, this is what we've gotten back, this is what we received, is this patient, can we do a final dispensation of that patient? So that's where that whole 140-minute part is coming in. So that 28 minutes at the outset is where the physician goes in, assesses the patient, orders the test, does those types of activities.
Okay, that's great. One's asking, is the patient in the bed for the 140-minute part?
Yeah. And so that's part of where we're doing some project work to try to get them out.
Okay. I mean, I think it's good to say, I mean, to look at the detail within the simulations, that's great. That answers Ron's question, which is perfect. And, for everyone else, if you do have questions on more detailed part, we can certainly get them into us, and we can go through them either today or we can send after. But I think that's all questions for now then, if you want to move on then, Todd.
Okay. And then I'd like to give another example, and this is for a future state. So we've done one with the current state, the ED, and some of the work that's going on there. But this is a future state with our OR renovation project, $31 million operating room expansion project, renovation, major remodel to the facilities to handle volume for the next 20 years. And so I was asked to take a look at the architectural plan, the future architectural plan, and say, does this fit? Do we have the appropriate number of admission beds? Do we have the appropriate number of operating rooms of PACU, post-anesthesia care unit beds, both for phase 1 for inpatients and then phase 1 and phase 2 for outpatients that are leaving that day? And so I was handed the schematic and grabbed our reports from the OR to look at our process flow. As opposed to building out a new expansion area and then working on process, we can take a look at the process and how it fits the proposed expansion and make the changes we need to now, and also to the architectural plan if we see any types of bottlenecks or anything that's not going to work. So we wanted to test assumptions for capacity based on that expansion of the operating rooms and increased volumes over the next 5 years. And I'll go back here. So I'll go into our OR expansion. Excuse me. And as you can see, here's the layout here. These are on two different floors. We have the pre-op holding phase 2 and the PACU, as we're going to route people back. Pre-op holding is also going to be our phase 2 for those outpatients. And I've modeled them down here, not on top of this bed. But to, again, show you the complexity of how deep the process knowledge has to be to do this, I'll show you our routing. That's what it looks like. So it's very complex. Each of these lines is an individual route. Now, the great thing with Simulate is that you don't have to individually draw them because it has a replication function. So as long as I'm replicating these rooms and they perform the same way, I can replicate it and it'll automatically put all these arrows in. But you have to have a clear understanding of the process flow to successfully model, and you want to verify that it's a real world kind of thing. So here's our initial plan, and I'm going to focus over here on the pre-op holding and phase 2 PACU side, and take a look at what happens in the morning. So this would be a typical Monday morning. You can model it for every day of the week, however you need to do it. So over here we have our arrival rate. Now this is based on history plus the increased volume that we're projecting. We have surgery arrivals. You can go into the detail and look at the time of day. We have patients that arrive at, for first case surgeries, we have patients that will arrive sometimes at as early as 4 in the morning. Every 20 minutes, we have about 3 of those patients arrive, and it is a Poisson distribution, so we know that on average they arrive every 20 minutes, but that could be, you know, any time during that time. The 2 could arrive in 5 minutes, whatever. The model will account for that. And then, as you can see, as we get into closer to first case start times, they're arriving faster. So if we have this set, so our first case starts are starting about 7:15, 7:30 in the morning. I'll show you what happens here. This was the architectural plan, and really what I focused on when I looked at this model were these 2 elevators right here, and said, okay, is this going to support our flow, especially with increased volume? And so as I watch this model, this is the benefit. We can watch it. I can stop it along the way. I can see how we're utilizing our rooms. I can get data on that from the model. I've got my nurse resources up here, so that's something that we're going to extend into, is looking at our pre-op, our admissions nursing resources. So I have those. I'm watching those. I'm noticing those are okay. Everything seems to be running fine. But then I notice as I step through this, a little after 7 in the morning when people are heading to the OR, what starts to happen is we have a lot of people heading to our operating room, a lot of patients. And you can see this queue forming where the elevators are. Okay, so these first case starts, these early starts, we've held everybody, even if they arrive at 4 in the morning, to get them ready to go to the OR. So as I speed this up and watch it throughout the rest of the day, after the first case, it's not so bad. As you can see, the OR is working over here. It changes to an OR team when there's a patient in there. So we run it throughout the day. And then I look over here, and I'm looking at my elevator queue, and it's not so bad. 3.5 minutes for non-zero wait times. We determined that an elevator cycling up and down is about a 5-minute wait time because you have to get the patients and everybody off the elevator, send it back. All times, 0.6 minutes. Non-zero times, 3.5 minutes. We might say, well, that's not terrible. If we weren't looking at a dynamic model, we'd say, yeah, 3.5 minutes, that's not going to hurt us much. But think of the butterfly effect and the ripples that we see. So our results on these outpatients, 20 of these outpatients a day, 399-minute average, their throughput time, matches reality pretty close. So we say, well, what happens if we simply add another elevator? Because that looked like a bottleneck. Let's see what can happen if we added another elevator to the plan. We run this. So here comes everybody again. So I step through it. The queue isn't forming like it was before. People were getting through pretty quickly. Okay, so we made it through that. And then we speed this up, and we look at it run through the rest of the day. So let's go look at our queue here. Oops. We see that's dropped to 0.12 minutes on average. Non-zero times, 1.44 minutes. Only 5 people had non-zero time, so most of those teams were able to go right on. So we've dropped from 3.5 minutes to 1.5 minutes for the non-zero times. Doesn't seem like a huge change. But when I look at the overall throughput time, remember the butterfly effect and the ripples of downstream processes? 368 minutes, a 30-minute difference just by adding this third elevator to our process. Those queues build up, they back up all the other processes, and it makes a 30-minute difference to how we're flowing through our OR. So what does this mean? If I go back here to my slideshow, and I say, okay, we have 2 elevators, 399 minutes, standard deviation 146, to 3 elevators at 368 minutes and 143. Well, our OR charges, and this is a pretty accepted industry number, the operating room opportunity cost is $54 a minute in wait times and operating costs. And so with heavy volume and with continuous demand for our ORs, which we have, a 30-minute difference per case, 30 minutes times 54 times just on this side 20 per day. The ROI on the elevator, just by increasing your capacity in your OR, the break-even will come in about a week. And this is a project that's going to last us 20 years. So we take this, we sit down with the OR team, we vet it out, they say this is reality. When I ask them, do we have elevator problems now? They say yes, that's one of our biggest problems. The people are just jammed up waiting for those things. We went in, sat down with the architects, showed them this, and made the decision pretty much on the spot with executive leadership, yeah, we're going to add a third elevator to that plan, because we know that we're willfully introducing variation to the process if we don't. So that's a big deal. And when we look at the other side, the other OR side of those inpatients, the effect isn't quite as dramatic, but it still is 4 to 5 minutes per case, simply because there's fewer steps in the process of going through than to the phase 2 PACU. But 5 minutes per case, it's still in charge, operating room charges, it runs into the millions per year. Now, obviously, revenue is less than that, but the charges run into the millions per year. So this is a proactive solution that we've been able to do with Simulate just by modeling a future state based upon our current flows and ramping up and scaling up to what we believe it will be as a forecast. So our results, we identified the process bottlenecks and determined that the surge of patients transported for first and second case starts, that 2 was not adequate, and we would have staff, physician, and patient dissatisfaction by increasing that variation. So we added the third elevator, and the discovery of downstream increase in variation could not have been achieved in recognizing using static waiting line models. So if we're just using our regular waiting line models, queuing models, it would have been very hard to understand the full impact of that minor change in wait time downstream. So our next steps with the OR is we've launched some Lean Six Sigma projects to streamline our scheduling processes so that we're scheduling people appropriately and having people show up at the right time, and then our OR room turnover processes so that we can continue to reduce variation and increase capacity. And so we've planned that for the next 20 years. And so really the benefits that we get from discrete event simulation, it requires us to develop a deep process understanding, which is always beneficial in any type of work that you're doing when it comes to process improvement or project management. It helps us to avoid tampering. So we don't want to go in the case of the ED, and just kind of make trial and error changes to the real-world process that could really affect satisfaction and even affect safety if we're not doing it in a thoughtful way. Helps us to create a shared visual understanding of the process for all parties. So we can take this in, throw it up on a boardroom screen, show executive leadership, show architects, show anybody that we need to how the process runs. We can vet it out to make sure that everybody's on the same page, that it matches our real world and what we're seeing. And then we have a visual understanding. And that's why I like to use floor schematics, because it really makes it real for people, because they say, this is my world and this is how I work. And then it allows us for observational analysis and modification without physical intervention, which is what I spoke about, offline trial and error. And it supports our improved decision making through management by fact. So we're actually using statistical analysis and actual mathematical physics to determine how the process is going to perform based upon the changes that we implement. Are there any questions on the OR simulation?
Well, again, Todd, I think that's a really powerful example that you've shown us. And one of my questions is about how the time it took for you to do that, because one of the questions we get asked is well, how much time do I need to spend on building a simulation like that, and what's the ROI really of using simulation? Why wouldn't I use some of my other techniques? And I think you've explained so well why those other techniques wouldn't have helped. But I wonder if you could say how long it took you, how much time you had to invest in doing that.
Mm-hmm. To do a simulation, it took me about 60 hours for each of these of actual building the simulation. When you build a simulation, you can plan on about a third of your time actually building it, and then 2/3 of the time in building the simulation in debugging it, because you want to get a real world simulation. So you want to make sure all the numbers are correct and that that you've got all your distributions entered correctly. So with the OR, it was about 60 hours. I actually had a little bit of a time pressure. It was put before me on a Friday, and I said, well, when do you need it? They said, well, we're meeting with the architects next Friday. And so I suspended a lot of other activity that week and was able to get it done in approximately 60 hours. But the ROI, as you can see, really can, depending on the process, like the OR, with our increased capacity, it really could run into millions of dollars a year. So really to have a black belt or someone trained in this area, put 60 hours into it is not that heavy of an investment for the benefits that you can get out of it. And just a note on who we train on it, really at this point we have this as extended training for people that are going to be master black belts in the organization. We have our black belts that lead our projects and our process improvement. I'm a master black belt, and so I've done the simulations to this point. We've trained another one of our black belts up to the master black belt level. He's going to be our second master black belt in the organization. He's been trained on simulation. So we're really expanding the capacity, because then we can collaborate in debugging for each other. We can share our simulations back and forth. We have the ability then to question assumptions, because in any simulation there's a few things that you'll have to make educated assumptions on. And so if you have data available in collecting it through reports that you have from your OR system or your ED system, and it's really not a horribly long process, but it is very intense, and it takes a deep process knowledge.
Yeah, thanks.
I guess a question to follow on from that is what we have on, we have a wide range of people who are tuning in today, and, from the very experienced where simulation is ingrained in the organisation to those that are just starting out. And, question that we always like to ask to experts like yourself is to say, what advice would you give to start to show the value? And one, well, I guess for me, from an interest part, would be, when did Memorial MHS still start to use simulation, and how did you guys get started, and what advice would you give to people who are just starting out and trying to prove the value?
We started, I guess it's been, I'm trying to think of when I first did this, about 1.5 years, 2 years ago. Now, I had done this in a previous organization, previous healthcare organization. I'd done some simulation work, so I had knowledge of the process when we brought it here. Advice I would give is probably model something that currently exists first, even if it's a fairly simple process. And you can really gain buy-in by showing how you can match the real world by developing a current state process. And then when you show it to the stakeholders, work with the stakeholders, get their buy-in, have them give you plenty of feedback. Say, they're looking at the different parts of the simulation, show it to them. Have them verify its validity, and that's going to get you a lot of buy-in. And then, I would say keep it simple at first, and just do a simple process. Doesn't have to be a big complex ED environment, but you may just look at a throughput process. One of the things that we looked at was our time with a CT scanner, and just how long people are waiting and getting out. It's really a pretty linear process. But train a small number of people. Don't try to train the whole organization. Maybe have a couple of people that are very good with statistics and data analysis to train on this. As I said, you don't have to be a computer programmer. You can be. That's kind of the neat thing. It can use visual logic, but with the simulate program that we use, there's a lot of drag and drop as well. And so if you have a deep process understanding, you can start to build your simulations. But that's probably the best advice I can give.
No, that's great. Thank you for that. There's a few other questions that we do have on, but we realise we're getting close to the end of time, and I know that we'll just get one more in, and we can then wrap up and let people move on. And that final question is from Jarvis Gray, and he asks, how detailed are the statistics for these simulations? For example, can we look at resource utilizations?
At the what utilization?
Can we look at resource utilizations?
Absolutely, absolutely. If you look into our processes here, if I go back to our ORC, there's a resource, the nurse resource. I can look at that, and I can look at her results. That particular, there's the utilization for the resources. And if you have the professional version, you can actually develop sub-processes. So it can be very detailed. You can develop a sub-process in here, which would almost open up like another little window and have a little sub-process there. The statistics themselves aren't extraordinarily complicated. If you have a basic understanding of data distributions and arrival rates, just like you would with a static model, like an MMC model, where you know how many provider resources you have, or whatever resources you need. You know the arrival rate, and you know the average length of time in the system. That's going to get you most of your simulation work. As I look at our work here, let me see if I can bring one up for you. Like the time here, and I look at my results, or I look here. I just have the average time. I can pull those from a basic report. If you look at the milestones, a lot of crystal reports, those types of things in the OR have milestones. I can determine what the average time is, and then I can choose my distribution. Often, exponential arrival rates, Poisson arrival rates, exponential service times are going to get you where you need to be, and that's what's great is the computer program is powerful enough that it does all those complex calculations instantly for you. So as long as you know the basic data distributions and have an understanding of those, you'll be in good shape. And there's actually what we call a stat fit piece of this where you can actually put in your distribution or put in your data, and it'll tell you what type of distribution it is. So there's a lot of tools involved that can help you to determine those things.
Okay, good. Jarvis has just asked one question again to finish you off. Is there any way to optimize resource automatically, or do we need to try different scenarios?
Optimize resource automatically. Yeah, you can schedule things. So with Advance, you can develop schedules. I look at my PACU nurse here. I can put in travel. I can program in the travel time if they're moving around. I can develop schedules, shift-dependent schedules. So you can do a lot of optimization, different types of things. If you want to change conditions to the simulation itself, it's very easy. You just generally have to go in and, like, if I want to change my arrival rate, I can just go into the detail and I can simply change it. So yeah, there are a lot of different tools involved that you can use.
Yeah, that's good. Jarvis, I know you've got a few more questions on there, but I realise we're getting close to time now. So on your last slide there, Todd, you had your own email address for anyone to get in touch, and certainly I would believe you'd be open to Jarvis getting in touch.
Absolutely. Please feel free to contact me. You can either call or email, and I'll be happy to speak with you and answer questions that you may have.
Perfect. Well, that just remains for me to thanks again to everyone for joining us today. Thanks especially to Todd. Another fantastic presentation and look into the benefits of simulation in improving healthcare. We will get details out of the next workshop, which will be in June, on health economics, and we'll get that out to you shortly. And I'll also send round a recording of the workshop today. And thanks again to everyone for joining us, and have a great day.
All right. Thank you.
Thanks, Todd.